last case I'm going to show you is somewhat similar. It's a 68-year-old female with hypertension, high cholesterol, diabetes, and smoking who developed a plantar surface ulcer on the left foot with an associated infection. Her preoperative studies demonstrated significant SFA pop disease and a reduced ABI and toe pressure. So she was taken to the operating room for an arteriogram. Again, this was done through a contralateral femoral access up and over approach. The arteriogram demonstrated that she had a short stump of patent superficial femoral artery followed by a total occlusion and reconstitution of the popliteal artery, which was diseased above the knee, and 3-vessel tibial artery runoff was identified. So in an effort to pass through the occluded SFA pop segment, the sheath was brought up and over, and we attempted to engage the short stump of superficial femoral artery. However, every time we were attempting to pass the wire or the support catheter, this would prolapse into the profunda femoral artery, and we were unable to successfully get any wire or catheter purchase. We were only able to get a short segment of 014 wire through the superficial femoral artery stump, but could not pass with any meaningful degree the crossing catheter. So at this point, I elected to use the Shockwave Javelin catheter to successfully pass through that proximal cap, but also in an effort to try to stay within the true lumen once I was able to get through that short stump and the proximal cap. So with a short amount of 014 wire purchase into that proximal superficial femoral artery, I brought the Shockwave Javelin catheter into position under roadmap guidance while advancing with gentle pressure over the short segment of 014 wire I had into position and delivering lithotripsy pulses. We were able to advance through the proximal cap successfully. The wire was then advanced easily throughout the remainder of the superficial femoral artery and popliteal artery through the area of distal reconstitution. The Javelin catheter was slowly advanced through the entire segment that was occluded while delivering lithotripsy pulses. At the distal cap where the reconstituted popliteal artery segment was, we delivered additional pulses and spent time here at the distal cap in order to facilitate luminal gain and energy delivery at that site as well. So the bulk of the lithotripsy pulses in this case were delivered at the proximal cap in order to advance through, as well as the distal cap where it reconstituted in the above knee popliteal artery. And all 120 pulses were delivered with that approach. Following this, as you can see, there was luminal gain and a flow lumen established throughout the superficial femoral artery. Definitive therapy was performed with a drug-coated balloon angioplasty followed by a self-expanding stent. And the completion arteriogram demonstrated an excellent technical result with a widely patent superficial femoral artery and popliteal artery with brisk flow and 3-vessel runoff distally, which you can see significantly improved flow to her foot, which is a nice radiographic result. Postoperatively, she had significant improvement in her vascular lab studies with normalization of her ankle brachial index and a significant improvement in her toe pressure. But most importantly, she was able to clear the infection and she ultimately healed her plantar surface ulcer. So a very nice radiographic and clinical result.